Good morning, everybody, and Assalamu alaikum wa rahmatullahi wa barakatuh. It's a pleasure to be with you all. So it gives me really a great honor and a pleasure to really share some thoughts with you and to learn from each other about another tool that will help our type 2 diabetic patients to reach their objective. So I'm really going to discuss the data related to dulaglutide or Trulicity, and this is the outline of the presentation. So I will start by drawing the distinction between the randomized controlled trials and the real-world evidence. What's the relevance to us as a clinician to learn about the real-world evidence? The gaps in medications efficacy, is there a difference in response rate to medications when you do the randomized controlled trials and compare them to the real-world evidence trials? And then I will touch into an extremely important point, which is differences in medications adherence and persistence among GLP receptor agonists, among the subclass. And then the impact of this adherence and persistence on glycemic efficacy. And then I'll share with you some new data, emerging data concerning the therapeutic efficacy of various GLP receptor agonists in the real world before I conclude, and then briefly I'll go through a case presentation. So, randomized controlled trials versus real-world evidence. What is the relevance of both of these entities to us as clinicians? Well, I think one may view it as moving from randomized controlled trials to real-world evidence as of moving from the bench studies to bedside. So the randomized controlled trials are obviously well conducted, well designed. They select candidates who will be giving the medications. These candidates should be generally healthier with limited comorbidities. The fact that they volunteered to the studies, it implies that they are obviously motivated and they want to share in advancing the knowledge. Subject will be in a meticulous way followed up quite frequently. Their adherence is really second to none. So that's really what we do in the randomized controlled trials. And then if we compare it to the real-world evidence, in the real-world evidence, we don't select a specific population. Generally, we don't exclude patients from taking these medications, except obviously if there's contraindication. So we deal with a large, diverse populations with multiple comorbidities. In randomized controlled trials, obviously we see patients quite frequently, sometimes every few weeks, every month, every 2 months. But in the real world evidence, obviously it is our clinical discretion. We are going to see them every 3 months, every 6 months, whatever. They don't come to the appointment and then you give them another appointment, so on and so forth. Randomized controlled trials are generally short follow-up. So you can see from the data that has been presented by my colleagues, Dr. Prasad and Dr. Farouk, obviously the data is up to 6 months, a maximum a year. But in the real world data, it's endless. So you can follow patients for long-term follow-up to tease up some of the facts that you are after. Okay, so that's really the differences between the two, setting the scene. Is there a gap in medication efficacy between the randomized controlled trials and the real-world evidence? And there is really a suggestion that when you do the obviously clinical trials and you see a meaningful improvement in the HbA1c, but then when you do the when you give your medication to the patient, you don't see exactly the same thing. You see what you call a suboptimal response. So that's what that's what one comes across in the real world evidence. We don't see, if you like, as much of a robust response that we have seen in clinical trials. And this has been really documented. So this is the data by Polonsky, and he really went into the incretin-based therapies, DB4 inhibitors, and GLP receptor agonists. And he analyzed 11 clinical trials. And what he demonstrated by pooling these trials with GLP receptor agonists, and these are all GLP receptor agonists, not a specific one. He saw an HbA1c from the randomized controlled trials fall of 1.25%. But then, when they analyzed the real-world data, from a similar baseline of 8.3, the fall in A1C was a mere 0.5%. So there is a gap in the response between the randomized controlled trials and the real world. And again, he observed similar gap when they looked at the DB4 inhibitors. And that really raised questions, why do we see this? And if we look at our data and others' data, so this is our data from Sheikh Khalifa Medical City in Abu Dhabi, and this is the data from elsewhere in the world, we can see that the proportion of patients who are reaching the goal of less than 7% for instance, in our study, was 40%. And similar data was reported by the NHANES, United States, and Europe, and so on and so forth. So a big proportion of patients depicted by the red really shaded in these pie charts are not controlled. And the question is why they are not controlled, although we have growing understanding of diabetes, although we have newer medications, we have better technologies, but still about 50% of our patients are not controlled, despite all of the improvement that we have seen over the last 10 to 15 years or so. And this will take us to the issue of differences in medications adherence and persistence among GLP receptor agonists. And if you look at the data to the left here, as you can see, this is the adherence at 1 year, and the adherence in every individual was defined as sticking to the medication for more than 80% of the days within the year. So if you take your medications for more than 80% of the days within a calendar year, then you are defined as adhering to the therapy. And we can see that based on that definition, the adherence to therapy was about 50% give and take among different classes of diabetic medications, DB4 inhibitors, sulfonylureas, thiazolidinediones, and then GLP receptor agonists. And then if you follow patients for the second year, actually the adherence falls further. So this was depicted by the red columns. And this is really a major problem in managing subjects with diabetes. And then if we look specifically at the DB4 inhibitors and GLP receptor agonists, and we look at the persistence, and persistence implies the days that you continue the therapy uninterrupted. You can see that it was very limited for both medication, for GLP receptor agonists and for DB4 inhibitors. As a matter of fact, after 8 months, when you look at GLP receptor agonists, you can see that about only 30% of subjects are persistent with the medications. And this is really intriguing. And here, I'll share with you the data on head-to-head between different GLP receptor agonists. So to the left is dulaglutide versus liraglutide and the persistent rate. And what we can see evidently is that the persistence falls throughout the year, but there's lower persistence with liraglutide compared to dulaglutide. Similarly, when you compare the dulaglutide with the weekly exenatide, both are weekly preparation, you inject them once a week. Again, the persistence with the exenatide weekly was inferior to that with dulaglutide. And one may, again, put the question why we see the differences in this persistence. Maybe it's here to the left side, we're taking daily versus weekly injection. That's one thing. Number two, the titration. No titration with dulaglutide. Number three, perhaps is the device. It's the hidden needle. We don't see the needle. So the needle phobia becomes less of an issue. All of these together, and we've heard from Dr. Farouk about the patient preference to therapy when they were given this new novel device. Patients preferred this device because of the ease of administration. It's a very user-friendly. But anyway, back to our subject, persistence was superior with dulaglutide compared to exenatide weekly and compared to daily liraglutide. And here, data from Italy, again, looking at persistence with medications, and we can see the best persistence was seen by the dulaglutide depicted by this green curve, compared to liraglutide, which was depicted by the blue curve, and then we have the shorter acting ones, which have even inferior persistence. What is the impact of this adherence and persistence on glycemic efficacy? Well, if it has no impact, then it doesn't matter. But if it's impactful on the efficacy, on the glycemic efficacy, then it matters a lot. So let's see the impact. And again, back to the data from Polonsky, and he demonstrated that the gap in the response and between the randomized controlled trials depicted in green and the real world depicted in red is primarily because of the adherence. So when there's poor adherence, you get less of an efficacy of a medication. Do we have more data? The answer is yes, we have more data. So this is the data from Modi. Again, last year, the data came out, and what it showed that regardless of the GLP receptor agonist that you're using, whether it be it dulaglutide, Trulicity, or liraglutide, or comparing dulaglutide to exenatide, the subject who adhere to the therapy have a better A1C reduction compared to those who don't adhere to the therapy. But again, what we can see, a rate of adherence is more for dulaglutide compared to liraglutide, and more for dulaglutide compared to exenatide. And if we look at here, again at dulaglutide versus liraglutide or versus exenatide, we can see that thanks to the adherence rates with dulaglutide, and these are unselected group of subjects, those who had better adherence had better A1C reduction. So the A1C reduction was superior with Trulicity compared to liraglutide, superior with Trulicity compared to exenatide. Okay, now let's turn our attention to the therapeutic efficacy, again, among different GLP receptor agonists in the real world, a data that came actually only a few months ago. To be precise, it came in May of this year, comparing dulaglutide to liraglutide to weekly exenatide in 2,400 patients, uncontrolled diabetes, aged 18 to 80. And if we look at the data, and when you analyze it, comparing dulaglutide, weekly exenatide, and liraglutide, and you look at the efficacy data, you can see that the HbA1c reduction, when you do the intention to treat analysis, was significantly better for dulaglutide, as we can see in this first plot chart, compared to liraglutide. Significant difference, 0.6 with liraglutide, 0.9% with dulaglutide. And if you say, no, I don't want intention to treat analysis, I want as per protocol or as treated. So these are patients who confirmed that it took repeat prescriptions. What they demonstrated yet again, superiority of dulaglutide in the real world compared to liraglutide when it comes to efficacy. And then if we look at the meta-analysis, so this is a meta-analysis of 4 studies looking at the efficacy in this. We can see that there was significantly more efficacy with dulaglutide depicted in this diamond shape, which represent the pooled data from the 4 studies compared to liraglutide. And if you look at the weight, was there weight differences between the two? As far as the weight impact was similar between dulaglutide and liraglutide in this real-world data. Both resulted in a reduction in weight, but there's no differences between them. And again, comparing dulaglutide with weekly exenatide, we can see that superiority of HbA1c reduction, although both are weekly, but probably because of the better adherence, probably because of the better device, because of the hidden needle, because of the simplicity of using the device compared to the cumbersome device of exenatide, that resulted in better adherence and with it superior A1C reduction. And when it comes to the weight, again, meta-analysis from pooled data from 2 studies, the weight reduction was superior for dulaglutide compared to weekly exenatide. So, ladies and gentlemen, I think before I go through the case discussion, let me conclude the real-world data. And I think to conclude from the real-world data, one can state that there's a substantial number of patients with type 2 diabetes who were not controlled, despite the fact that we have ample choices of therapy for our patients. Lack of adherence, as I shared with you, represents a major driver for lower effectiveness of anti-diabetic medications. Throughout the award program, as Dr. Farouk pointed out, and as Dr. Prasad pointed out, Trulicity has proven to have a robust HbA1c reduction with good tolerability and no safety concerns. Real-world studies consistently demonstrated higher therapeutic efficacy and effectiveness of dulaglutide or Trulicity when compared to other GLP receptor agonists, including daily liraglutide or Victoza. So to conclude, ladies and gentlemen, GLP receptor agonists can be used throughout the disease continuum from early type 2 to more advanced type 2 diabetes. It can be used as monotherapy in subjects who are intolerant to metformin, and it can be used as part of combination with oral therapies and with insulin. GLP receptor agonists are very efficacious when it comes to A1C reduction. We saw that from the real world, from a Trulicity study. They are not only lower A1C, but let's not forget that they result in weight reduction and improvement of cardiovascular risk markers, including blood pressure and lipids. They are associated with very low risk of hypoglycemia. Indeed, long-acting GLP receptor agonists, obviously like Trulicity, less injection frequency, improved delivery device, and this translated into superior efficacy and superior A1C lowering in the real-world data. GLP receptor agonists, and this is really not a subject of our talk today, but they reduce MACE in subject to established cardiovascular disease, and some of them in subject who have multiple cardiovascular risk factors. And with this, I conclude my presentation. Thank you for your attention.